Assalamu alaikum. Good evening. My name is Nimr Al-Jaid. I am a neonatology consultant at Al-Hada Hospital in Taif, and I will be the moderator for today's activity. First of all, I would like to thank you all for being with us today, and I would like to thank Dr. Adnan Hadid for organizing today's activity. And also, I want to thank Dr. Abdurrahman Nimri for supporting this series of educational activity. Today, our speaker is Dr. Tala AlTamimi. Dr. Tala AlTamimi completed his pediatric training in Saudi Arabia. He then completed a fellowship training in perinatal and neonatal medicine at Western University in London, Ontario. He then completed a fellowship in neonatal hemodynamics and point of care ultrasound. He's performing target neonatal echocardiography, lung ultrasound guided procedure, including ultrasound guided peripheral vascular access. His research interest is in BPD associated pulmonary hypertension and ultrasound guided vascular access. Dr. Tala AlTamimi is currently working as a consultant neonatologist at Imam Abdurrahman bin Faisal University in Dammam. Dr. Tala, if you are ready, the mic is yours to start your lecture. Hello?
Okay, thank you very much for the introduction, and thank you for allowing me to speak about a topic I'm very passionate about. Really. So I'll be talking about tailored hemodynamic management after neonatal septic shock. I have nothing to disclose. And first of all, we want to start with a few case scenarios, just to see if we're all on the same page, if we will use the same approach for all of those patients or not. So it's about Khalid, Nof, and Ahmed. So let's take the first one, Khalid. This is a 27-weeker, now 24 days of life. This baby was pretty stable on CPAP, PPF7, F5 to 27%. Started to have apneas, DSATs, and brady requiring intervention. Eventually, this baby was intubated on the conventional mechanical ventilation, high frequency, and high FiO2 for 100%. The vital signs of those babies is the heart rate is 122 on the is 30/15 with a map of 20. Baby has a capillary refill of more than 3 seconds. Let's move on to Nof. Nof is a 28-weeker, day 18 of life. Was also stable on CPAP and doing fine. Started to have a picture of neck, feeding intolerance, vomiting, and apnea. So suspected neck versus late onset sepsis, antibiotics was started. The vital signs for Nov is 59/18 with a mean of 31. And her saturation is also fine, so is her capillary refill. Ahmed, on the other hand, is a 32-week. Now day 2 of life. Is also stable and started to desat. FiO2 of around 60%, eventually intubated on conventional mechanical ventilation. Sepsis was suspected, so antibiotics was started. So this baby had a blood pressure of around 45/25 with a mean of 30. The saturation was 90%, and his capillary refill was 3 to 5 seconds. So many numbers here. So just to summarize it, so Khalid, 27-weeker, and has a mean arterial pressure of 20. So if we're going to use the definition of gestational age or equals gestational, mean arterial pressure equals gestational age, then by definition, this baby is hypotensive. Nof is not hypotensive. She's neurohypotensive with a map of 31. And Ahmed is hypotensive with the blood pressure of 30, and he's a 32-weeker. So what is the next course of management in all of those babies? Are we going to treat this hypotension? Are we giving a fluid bolus and starting dopamine? And are we going to treat it, but we're starting NorEpinephrine, or we're starting Epinephrine, or we're going to continue monitoring the blood pressure? Now, I'm not going to take any answers right now because I think, including myself, that we've all been through this conventional management of hypotension, where we start with fluids in the beginning. If that doesn't work and fix the problem, it's going to be dopamine. We escalate our doses, move on to dopamine. That doesn't work, epinephrine or NorEpinephrine, and so on and so forth, and also give steroids. And this has been well described for a long period of time. And I think everybody practicing neonatology is very familiar with this approach. Now, what if I tell you that we did an echo for those babies? And this is the images that we're seeing. They're quite different. And each one of them is actually showing us a different pathophysiology. So the first one, Khalid, is a 27-weeker. You can see here that the ventricles are barely moving in the left ventricle. There is no area change at all. And this is the mitral valve barely moving. The right ventricle also barely moving here. Nov here, on the other hand, although that she has normal blood pressure, 31, you can see that the size of the left ventricle in systole is very small. So there is very low preload in the left ventricle, and the ventricle walls are actually kissing each other. So this is a state of low preload. The last one, Ahmed here, is hypotensive, but if we look at the short axis peristernal, we see that there is flattening of the interventricular septum. So this is the right ventricle, and this is the left ventricle. And in systole, you can see that the ventricle is almost flat. So this is significant for pulmonary hypertension. So essentially, those two babies, Khalid and Ahmed, are both hypotensive, but they have a different physiology completely. And Nov, although that she has normal blood pressure, there is disturbed hemodynamics, there is a disturbed perfusion. And if we wait a little bit more, this baby will go into hypotension. So what is the physiology in each one of them? We talked about this. So this is a poor systolic performance, poor cardiac output. Nov has low systemic vascular resistance, and Ahmed has pulmonary hypertension and possibly low preload to the left ventricle because of decreased left atrial filling, not enough blood flow coming from the lungs. So at this point, we'll ask the same question. Are we going to treat her hypertension? Are we giving them fluids and give them all dopamine? Are we going to give them all norepinephrine or epinephrine? Or we're going to continue monitoring? I think now we can see that different presentations with different echo pictures really shows us different physiology. So my goals for today's talk is to talk briefly about the stages of sepsis, and also talk about the relationship between blood pressure and tissue perfusion, and also talk about the common patterns of shock in neonates. And is there any difference between term and preterm heart in the response to sepsis? We're going to talk extensively about cardiac focus and how to differentiate it from targeted neonatal echo or a hemodynamic assessment. And we'll talk about the take-home messages that I really want to relay from this webinar is the physiology-based approach, because really we cannot expect that everybody can do a hemodynamic assessment, but we expect everybody to understand the basics of physiology-based approach. And then we're going to conclude with some scenarios. So sepsis, although that there is so many advances in treatment of neonates, sepsis is still the #1 killer, and the mortality hasn't really gone down. And around 50% of babies, especially preterms that have hypotension and require cardiac medication, have a mortality of around 50%. So still, we're not really doing a great job in that domain. Now, the problem is that we're probably focusing on this stage, which is the septic shock. So what happens really in the heart and the body as a whole, that there is element of fluid depletion, systolic LV dysfunction, RV dysfunction, diastolic dysfunction that we really don't know a lot about, pulmonary hypertension. The afterload is either high or low, and also to complicate it even more, there is a lot of cardiac shunts. But what we really focus on is just hypotension, which is the tip of the iceberg. And we fail to recognize all of those subtle changes. And with that, unfortunately, we're targeting the baby once the baby reaches this stage. And this is quite an irreversible or difficult to reverse state. And we shouldn't aim to treat the baby right here. We should actually aim to treat the baby early on in the disease. And this is the early targeted intervention. Now, some may say that the blood pressure is fine, so the baby's perfusion is fine. Now, in the early 2000s, they look at a marker of blood flow, which is the superior vena cava. And they looked at the correlation between low superior vena cava flow and blood pressure, and there was a poor correlation. So in theory, you can have babies with normal blood pressure, but with very bad systemic blood flow, and vice versa. Therefore, blood pressure and tissue perfusion are not interchangeable. So the classic phenotypes that is well described in the adult and the pediatric literatures, the warm shock physiology and the cold shock physiology. In the warm shock physiology, you have a low systemic vascular resistance state. Classically, you're going to have warm extremities, normal capillary refill, and bounding pulses. In the cold shock physiology, you have a high systemic vascular state, cold extremities, delayed capillary refill. Initially, a normal blood pressure, sometimes a little bit higher before it goes down. Now, what happens with the warm shock physiology, that initially there is systemic vasodilatation, and this systemic vasodilatation will actually decrease the blood coming back to the right side of the heart. Therefore, there is decreased venous return. And this will decrease the amount of blood going to the lung. So you're going to have decreased RV preload. And whatever goes to the lung has to come back again to the left side of the heart, which is the left atrium. Therefore, the amount of blood coming to the left atrium is small. That means that there's a low LV preload. And eventually, the heart will try to compensate by pushing more of blood until it cannot tolerate that anymore. And you're going to have decreased systolic performance, decreased cardiac output, and shock state. In the cold shock physiology, it starts actually with the increase in the afterload. With the increase in the afterload, it is difficult for the heart to push against that increased afterload, and it doesn't have the capacity to fill at diastole anymore. So your stroke volume actually decreases, and the LV filling decreases. And eventually, you are going to have a low cardiac output and shock. So in the adult population, the warm shock physiology is a bit more common than cold shock. In children, it could be either cold or warm shock, but it's predominantly cold shock physiology, although this clear distinction now, I think, is fading away. But with neonates, unfortunately, it's quite variable. But why do we have this variability? So many factors that come into play here. So, for example, here, this interesting study where they looked at inflammatory mediators in term and preterm babies above 32 weeks and below 32 weeks. Smaller gestational age, they have low or less number of pro-inflammatory mediator and less also anti-inflammatory mediator in comparison to term. Interesting study they did on animals where they were actually not studying where they were studying actually the pulmonary hypertension, and they injected those animals, I think there were lambs with group B streptococcus toxins, and they measured the cardiac output. The cardiac output actually started to decrease. And from our formula, which is the mean arterial pressure equals cardiac output multiplied systemic vascular resistance, we can assume that the systemic vascular resistance is higher in those babies, meaning that there is more of a cold shock physiology. Also, it's anecdotally known in the literature that gram-negative E. coli typically present more with a warm shock physiology. And it's interesting diagram here that kind of summarizes also differences in the in multiple organs in preterm babies versus term babies. So this in the heart, you can see that those preterm babies are actually born with some sort of diastolic dysfunction. The hearts are stiffer. They have lower number of myocytes and cardiac mass, and they have decreased compliance. Also, they have a lower response to Frank Sterling. So basically, the more stretch that you have to the heart muscle, you cannot get more force because the heart is running at capacity. The vascular bed is also different. The receptor expression is less, and the autoregulation capacity is lower. From an endocrine perspective, also, they have lower circulating level of catecholamines, and they have inability of synthesis or decreased synthesis, and they are more prone for adrenal insufficiency. Along with RDS and all of the other systems that are going to play a different role in making treating the preterm babies a bit more difficult. So the problem is also that the phenotype is dynamic. If we say that this is a cold shock physiology or a warm shock physiology, it may present in a way, but it can change with time. So if I assess a baby today, in 12 hours, I might have a different presentation and a different physiology at all. So frequent assessment is key. But the problem, what tools that we have for a frequent assessment? If we go, for example, for capillary refill and clinical bedside assessment, we can see that there are some pitfalls. For example, here, interesting studies done by nursing assessing capillary refill. They looked at brief pressure versus extended pressure in different parts of the body, and they got different numbers. Basically, you can get what number that you want based on how much that you press on the skin or on the baby. This is also looking at specifically those babies with low systemic perfusion, those with low superior vena cava flow. We see that there is a poor correlation between the capillary refill and those that are considered to be high-risk babies with low systemic blood flow. So now we're in trouble. If the bedside assessment is difficult and the capillary refill is not really very reliable, and the blood pressure is a whole story by itself. The method of which we're assessing the blood pressure, is it invasive versus non-invasive? How accurate is our reading? From which limb we are getting it? And also, we do not have a clear definition of what constitutes hypotension. Multiple studies and surveys looking at very big centers with targeted neonatal echo versus without targeted neonatal echo, they have different definitions. And also that if we wait for hypotension to occur, we are really focusing on late stages of shock. So here, where comes a hemodynamic assessment, which is quite different than your classical structural echo done by your cardiologists. So in hemodynamic assessment or targeted neonatal echo, we're looking at blood flow across different parts of the heart. We're looking at the left ventricular output to see if you have a high cardiac output versus a low cardiac output. You're looking at right ventricular output, which is a surrogate marker for your pulmonary blood flow as well. You're looking at the PDA direction, and we're looking at certain characteristics to try also to estimate your pulmonary vascular resistance. We're looking at objective measures of pulmonary hypertension, including eccentricity index and peak acceleration time. The function, so many other ways to assess function, including Simpson's biplane, and now coming from the adult world and becoming more popular in neonatal population is speckle tracking imaging. RV systolic performance. RV is the right ventricle is the ventricle that really nobody will focus on a lot, but it's very important in those preterm babies, especially with RDS and BPD and increasing incidence of pulmonary hypertension. The right ventricle can become dysfunction. So hemodynamic assessment will look into that. And also myocardial performance index, which combines both systolic and diastolic dysfunction. This is not a core competency that everybody should know, but this is just to explain what in hemodynamics we are looking at. So just to explain, for example, the left ventricular output, what we do exactly is we try to measure the cardiac output coming from the left ventricle. And we assume that the cardiac output is like a cylinder of blood coming out from the left ventricle. And to measure the area of the cylinder, you need to measure the diameter of that cylinder, if it's circular, and we're assuming it's circular, and then we assume, and we also measure the height of that cylinder. So the diameter is the diameter of the left ventricular annulus, or the aortic annulus here, from the hinge point to hinge point. And then we measure the VTI, which is the velocity time integral. Basically, it is how fast the blood or how far the blood goes away from the aorta. And by that, we will estimate the cylinder size, and that is your cardiac output. This is just to make you familiar with what we're doing exactly. So cardiac output is your heart rate multiplied by stroke volume. And this is load dependency. So it depends on your preload and your afterload, and also depends on your contractility. How do we utilize measuring the cardiac output in hemodynamic assessment? If from our formula, we know that the mean arterial pressure equals your cardiac output multiplied by your systemic vascular resistance. So let's take an example here. If we know that a baby has a mean arterial pressure of around 33, and we calculate our systemic vascular resistance, so it can be either low or high, and therefore we can delineate exactly which physiology or pathophysiology we're having in septic shock. Is it a warm shock physiology where we have high systemic vascular resistance, low systemic vascular resistance, or is high in a cold shock physiology? But some may ask, what will that change? I'm going to use dopamine anyway, because that's what I'm comfortable with. And this is quite really uncommon. A lot of countries, a lot of centers everywhere are still more comfortable in using dopamine as your inotrope used in the Norwegian network. And you can see the majority of the first line been there for a long time and people are comfortable with. And that's not necessarily a bad thing. But because it has been there for a long time, we actually know its side effects, and we know what it can affect the heart with. So interesting study where they look at the dopamine and the doses of dopamine given, and looking also at the mean arterial pressure, looking at the systemic and also the pulmonary. With higher, you can see that although the blood pressure increases with dopamine, your systolic pulmonary artery pressure is getting higher. Therefore, with dopamine, you can actually induce an element of pulmonary hypertension, because we know as well, and if you are inducing or increasing your pulmonary artery pressure, you're making it difficult for the RV to pump against this pressure. Therefore, it will dilate to the extent that it cannot dilate anymore and cannot push blood to the lungs, passing fibers from the right ventricle towards the left ventricle. وعليكم السلام.
دكتور طلال، اعتقد في شويه تقطع بالصوت، ما ادري اذا عند الاخ الدكتور نمر والبقيه.
ايه صحيح.
نفس
اذا ممكن دكتور طلال نوقف الفيديو، اعتقد ممكن يكون لانه حتى الفيديو الصوره بطيئه بتتحرك، ما هي متناسبه مع الحكي. So I think we can stop the video, it will be better maybe. شكرا جزيلا.
أتمنى يكون أفضل الحين.
Yeah, I think now it's much better.
Okay. So we were talking about how dopamine will increase your the systolic pulmonary artery pressure, and with increasing pressure, you're straining more the right ventricle, and it can become dysfunctional if it cannot accommodate anymore. And there are crossing fibers from the right ventricle towards the left ventricle. Therefore, what starts in the right ventricle is going to end in the left ventricle, and you will end up with LV dysfunction. So also, it has been shown that the dopamine doesn't really affect your superior vena cava flow, which is considered to be a marker of your systemic perfusion. Also, it causes decreased coronary perfusion. So you're straining the heart a lot. What other options that we have? So case series has been done on NorEpinephrine, and it showed that it actually improves the mean arterial pressure in babies that are term here in 35 weeks and above. So this is one of the medications that have been studied before. Also, you can see this also having an effect on preterm babies. The study was done in Montreal, where they looked at preterm babies and they started them on norepinephrine. Not only blood pressure has increased, but also clinical markers, including the urine output lactate, actually improved those babies. There are not a lot of randomized control trial. I think probably this is the only one available out there from my quick search, that this is looking at epinephrine versus dopamine in septic shock. And specifically in this study, they were looking at the alpha dosing of epinephrine, which is 0.1 and above. In the study, in conclusion, really, they did not find a significant difference in all of the babies. But when they stratified them into less than 30 weeks, they found out that there is more hemodynamic stability with those babies that are that have used epinephrine versus dopamine. So what makes dopamine? What makes epinephrine actually better than dopamine in that study? Another study that had looked at babies with severe hypotension versus mild hypotension, and they gave those babies dopamine, and they started to measure the ratios of dopamine versus the norepinephrine. Those babies with severe hypotension had higher accumulation of dopamine and were not able to convert it into the active component, which is norepinephrine. So there is something about preterm babies that they are not able to convert dopamine to norepinephrine. So it can be theoretically better to give them norepinephrine, which is the active component, directly. Finally, this interesting study published last year by the group in Toronto, SEGI, performed this retrospective cohort study. We're looking at babies that were started on norepinephrine versus on dopamine. And you can see here that the babies that were on norepinephrine had lower mortality at 7 days, and they have lower pre-discharge mortality and also lower neurologic insults. So they actually did better in this retrospective, although it is a retrospective study, but it tells us a lot, really. So I don't think there's a lack of understanding of what is the best medication to use, or what medication does what exactly. It is clear for everyone that norepinephrine, for example, has more vasoconstrictive effects in comparison to epinephrine, and so on and so forth. But the problem is, how can we utilize this knowledge and bring it to our bedside and make it change our management? Because what we commonly do right now is just stick to the conventional approach. So the major issue, in my opinion, actually is to identify those patients that are actually going through a certain physiology. There is a lack of clinical assessment tools, or it might be there, but it may not be very clear. And so it becomes a guessing game at this point. I'm going to use norepinephrine, you're going to use dopamine, and nobody knows who's right. And it's also difficult to send everyone to do hemodynamics training. That is not feasible. Nobody can have time for this. And this is not in a unit with one person doing management A and the other person doing won't be actually very uniform, and your outcomes may not be what you want. And you want to also educate the whole team, because a person overnight may use a specific medication that, from a physiology point of view, you find that it may not be the best one. So what can we do? How can we improve ourselves even more? So the conventional approach has been there for a long time, and we should probably, revisit this later on. I think that is much simple than doing an echo, much more simple than doing a hemodynamic assessment, was just doing a cardiac POCUS. And this will help us in initiating the appropriate management. Now, if we have the service of targeted neonatal echo and hemodynamic assessment, sure, we can use that the next day. We can confirm our diagnosis. We can also adjust our management. But again, even if we have the service available, it may not be available overnight. So what is the major difference between echo, T&E, and POCUS? Because sometimes they are used interchangeably, although they are completely different than each other. Point of care ultrasound requires minimal skills. It is something that you can learn quickly. It is something that can be learned from workshops. It requires minimal training. But targeted neonatal echo and hemodynamic assessment required extensive training for more than 1 year. It also requires being with a cardiologist in echo lab. And your traditional echo, that is also called the structural echo, which is done by the cardiologist, requires even more training and requires a person to become a cardiologist to really look for structural assessment. So think of point of care ultrasound at this point as a universal skill. Think of it of like an extension of your stethoscope. It is an extension of your physical examination. So training is available, training is there. There have been so many workshops last year, for example. This is all last year. A very active group, the POCUS Neo, have done several workshops. The last one was in UK. We've done a workshop in Riyadh under the Saudi Neonatal Society as well. And there was great people like Dr. Yasser al-Said, Dr. Mohammed al-Tayyib, Abdul Mawla. They did the crashing neonatal protocol. In National Guard last month, there was a workshop as well in Kuwait. Now in Kuwait, in the maternity hospital, they have a full team that is trained to do hemodynamic assessment. And I've been really proud with the progress that they have done. So how do we combine this? How do we reach this physiology-based approach? So our aim is to try to find out what physiology the baby is going through clues that we have, which is the blood pressure centiles, and looking also at the context and the way the baby is deteriorating and trying to find out what disease that we're having. But a main issue with this, that when we are focusing on hypotension or hemodynamic instability, we are mostly focusing on mean arterial pressure. And this is quite deceiving. Now, mean arterial pressure from the known formula that we know is around 1/3 of systolic and 2/3 of the diastolic. So, and your systolic blood pressure is actually a surrogate marker for your cardiac output. It is the force of the blood that is exerted on the blood vessels during systole. That's your cardiac output. But in diastole, this is a marker also of preload. How much fluid is in the blood vessels during diastole, and also it is a marker of systemic vascular resistance. And this is quite deceiving as well. So if we look at the blood pressure centiles for this baby, for example, if you have a 30-week baby that has a mean arterial pressure of 30, but has the systolic blood pressure 32/25, versus a systolic of 50/20. In the first one, we can see that there is low systolic blood pressure. And this means that the baby is having high afterload and poor transition.
دكتور طلال في تقطع احيانا عم يصير بالصوت
the other baby with a low diastolic blood pressure has actually vasodilatation. اوكي وعليكم السلام.
في تقطع بالصوت بين فتره والثانيه، ما بعرف اذا في سبب مشكله في النت او يعني احيانا عم يغيب شيء بسيط او عم يكون متقطع ما غير واضح.
اوكي انا احاول اني انا اكون في مكان فيه الارسال فيه كويس صراحه.
يا ريت.
اوكي اوكي ان شاء الله يكون افضل الان. So we were talking about systolic blood pressure is If it was low, then this means that your cardiac output is affected. And if your diastolic blood flow, diastolic blood pressure is low, this means that there is a vasodilatory physiology. But how do we know which one is low, which one is high? We look at centiles. Blood pressure centiles has been there for a long period of time. Group in 1995 started to look at normal blood pressure values in preterm babies. Zubro centiles also has been published a long time in the Philadelphia neonatal blood pressure group. And an interesting published by Afif Al-Khafash last month has clearly outlined the blood pressure centiles, which is the minimum that you require in each gestational age. And by looking at those centiles, you can really identify either one of them, how far is it away from our target. Also something available online in the NeoPeds Academy by the POCUS Neo group, Dr. Yasser and Dr. Mzaffar. They have interesting software that was developed in a company in New Zealand, where you put the blood pressure values and it tells you exactly on which centile that the blood pressure is on. And it will also help you to predict what type of physiology that you're having. So this is very helpful. And how can we utilize this information? So if the baby is having a low diastolic blood pressure, then the physiology is likely to be a low afterload. And low afterload can happen due to a vasodilatory shock, for example, low systemic vascular resistance. And it also can happen because of a PDA. Your patent ductus arteriosus will connect your systemic circulation into your pulmonary circulation. And the pulmonary vascular resistance is lower than the systemic. So you're going to get a lower afterload. It also can happen because of low preload, where you have hypovolemia. If your mean airway pressure is really high, therefore preventing venous return back to the right side of the heart, and therefore you have decreased pulmonary blood flow and decreased left atrial filling. Or you have a tamponade, which is a similar physiology, where the right atrium just collapses and cannot fill. Now, in systolic blood pressure, it is mostly, this is a common scenario, like in asphyxia and cardiomyopathy, and also in pulmonary hypertension. In pulmonary hypertension, you have decreased filling in the left side of the heart because there is no blood coming back. Now, in high afterload, this happens mostly in cold shock physiology and post-PDA ligation, where suddenly the heart is adapted to this low systemic vascular resistance state, and suddenly now the PDA is ligated, the heart is already enlarged, and there is not enough preload coming back from the heart that adapted to this. So it goes into a high afterload state and shock. Hypothermia is a well-known factor that causes an increase in the afterload. This is also very much observed in HIE that are undergoing cooling. Not only that they are asphyxiated and their heart is injured, but having hypothermia on top of it can actually put more strain on the heart and make it difficult to pump against this high pressure. Your afterload also increases, but not in your systemic circulation, in your pulmonary circulation, with increased mean airway pressure. You think of the mean airway pressure like it is tamponading your airways and the blood vessels in the lungs. And this tamponade will increase your pulmonary vascular resistance. Therefore, it is difficult for the heart from the right ventricle to push against this resistance. Now, if you have combined low diastolic blood pressure and systolic blood pressure, this is probably a late stage process of either physiologies. So this can happen in refractory pulmonary hypertension, in septic shock, cardiogenic shock, or severe hypovolemia. So what do we do right now? We're not going to use the conventional approach. We're going to use physiology-based approach, and the remaining thing is to use cardiac POCUS. And as I said earlier, we're going to use this just to initiate our management. But hemodynamic assessment is going to confirm our diagnosis and adjust it. And some may be afraid that this is not a well-established modality of treatment. There is no consensus about this. I think the leaders in point-of-care ultrasound around the globe have published this interesting expert consensus statement about using the point-of-care ultrasound in the crash neonate. And they have delineated all of the applications, including cranial, lung, heart, and intestinal. And the focus on the heart here was very specific and very well described. You're looking only on contractility, and that will help you to starting eye drop or not, to rule out tamponade, and that is easily done with point-of-care ultrasound. If you have an empty heart, meaning that there is a low systemic vascular resistance state and there is third spacing, so you can consider fluids. And also you can see signs of pulmonary hypertension that will not make you diagnose pulmonary hypertension, but raise the suspicion of it. And therefore you can initiate your management and try to get a consultation to confirm your diagnosis and also to rule out congenital heart disease. So we will just go through some images just to see what we are looking at in point-of-care ultrasound. And is it something that can be learned in short courses and workshops, and or it can be taught by a mentor in your institution or not? So the only views that you need to do to perform with point-of-care cardiac ultrasound is the apical 4-chamber and the short axis. And you can get so much information from only performing one view only. So we'll start with the apical 4-chamber here. So by putting the probe in around the nipple, looking at the right shoulder, you're going to open up your apical 4-chamber where you can see all of your 4 chambers in an anatomically position if you invert the image. So what do we see in this? So what do we see in this apical 4-chamber? We can see so many things. First of all, the most easy thing that can be seen is the contractility of both chambers. We can also, from a qualitative perspective, try to assess the size of the right ventricle versus the left ventricle and look at the underfilling of the left ventricle. We can also do color Dopplers to see any regurgitation in any valves. That can require more training. But let's look at this one, for example, and this is all true cases. On this side that you can see, this is a normal heart with a normal function. But this one, you can see that there is poor contractility. If you look at the left ventricle here, the walls are barely moving. The valves are opening and closing, but not all the way, and it's very slow. Same thing happens also to the right ventricle here. So this is very clear that this is poor contractility. If you see this on point-of-care ultrasound, you will probably not start NorEpinephrine, where it is a more vasoconstrictor, but you will consider starting epinephrine on lower doses or maybe dopamine. This is an interesting one. It's also a very common point-of-care ultrasound image that you see. Here that you can see that the size of the left ventricle is very small in comparison to the normal size here. What you can see also, it looks quite muscular. And this is not because it is actually muscular, but this is relative to the small chamber size and small amount of blood in the left ventricle. So this is the classical hyperdynamic circulation with low preload. If you see this in the heart, then you suspect that this baby may require more fluid, and this baby is probably having low systemic vascular resistance and or is third spacing. Also, from this simple image, you can see here clearly that the right ventricle size is bigger than the left ventricle, and it shouldn't be that way. The left ventricle in the normal image here is bigger than the right ventricle, and the right ventricle should be around 2/3 of the left ventricle. So this gives us a suspicion of pulmonary hypertension. And if this baby was hypotensive, I will probably focus on giving medication to increase your pulmonary vascular resistance, that can increase your pulmonary vascular resistance like dopamine. If you do an apical 4-chamber and look at just tricuspid valve, you can see that there is a clear tricuspid regurgitation from this side, and this can give you
الصوت كأنه غاب دكتور طلال.
ventricles. Yes, I'm sorry, you can hear me?
Yeah, but عم تجي فترات الصوت كأنه عم يغيب بشكل كامل.
Now better?
Yes.
Okay, so also going back to the parasternal short axis, you can focus on many things, which is also contractility from a qualitative assessment. You can also look up filling of the left ventricle. Let's look at the examples. I think it is very difficult for somebody to miss poor contractility in this patient, where you see the short axis, that the valves are barely opening, the heart is barely moving. This is poor contractility at late onset, in late stage shock, in comparison to normal function here. With practice and learning, we can measure the ejection fraction and shortening fraction. Here in the parasternal short axis, we have suspicion of suprasystemic pulmonary pressure by looking at the intraventricular septum to see it pushed towards the left ventricle. So those things can look a little bit intimidating in the beginning and complex, but with training, with the right enthusiasm, and I've seen this with so many trainees, this can be picked up very easily, and it is quite safe to limit the indications and the images that you do to only the things that will give you an yes or no answer, and also to focus that this is not a full echo. To consolidate what we have, let's do a few scenarios. Maybe Dr. Numero, do you prefer to take questions right now or after the scenario? What do you think?
It's okay, but after the scenario, we can open for a question.
Right. Okay. So let's take the first scenario here. So if you have a 27-weeker, day 14 of life, this baby started to have clinical signs of infection with mottled skin, increased oxygen requirement from just 30% to 45%. Urine output also dropped. It was previously 4 and now became 1.5. The blood pressure is 40/20 with a mean of 26. But if we look at the trend of the blood pressure, actually 4 hours, it was higher than that. It was 47/25 with a mean of 32. So in this case specifically, if we are going to look at the mean arterial pressure in comparison to the gestational age, it is not low, it is actually normal. But we can see that there is a downward trend in the past 4 hours, accompanied with clinical deterioration. So this means that this is a significant drop and a significant drop in your systemic perfusion. So what we will do here, are we going to treat this hypotension? Are we going to give fluids, dopamine, NorEpinephrine, low-dose epinephrine, all here, or?
There's some discontinuous in the scenario. Dr. Talal?
Yes. Would you like me to go back?
Yeah, because sometimes we couldn't hear you during the
دكتور طلال انت في الشرقيه ما شاء الله عليك، انت في ابريفري النت عندكم ضعيف بالمره.
والله الشكوى والله دكتور
يعني في ديسكونتينيوس، لكن انا اتواصل بس احنا وي ار انجوينج ات.
طيب بحاول قدر المستطاع الحين. طيب so let's go back to this scenario. Is a 27-weeker at day 14 of life, started to have a mottled skin. Increase with the last 4 hours actually dropped from 4 ml per kg per hour to 1.5, which is still normal, but there is a drop. The blood pressure is 46/15 with a mean of 25. But before 4 hours, it was actually higher, 47/25 with a mean of 32. So this is an interesting case, and this is a real scenario, by the way, that if we are looking at the mean blood pressure only, it is normal for this baby, given that he's a 26-weeker. But during 4-hour period, there is a clinical deterioration along with a drop in the blood pressure of around 25% from the baseline. So that's a significant drop that indicates that there is significant deterioration. So what is the next course of action? Are we going to treat this hypotension? Are we going to give fluids and give dopamine? Are we giving NorEpi? Are we giving low-dose epinephrine, which is for beta action? Are we going to continue monitoring of blood pressure? Or are we going to treat the hypotension after defining the possible physiology? Let's look at the poll. Mumtaz. I can see almost 90% are actually saying to treat the hypotension after defining the possible physiology. Excellent. So that is the correct answer. So let's try to figure out what is the physiology actually. So if we look at the blood pressure centiles here, this is a 26-weeker and has 46/15. So if we go here, 26, the systolic blood pressure, the minimum is 36 and 46 is above that. So the systolic is fine, but the diastolic is low and the mean is actually normal for this baby. So there is only an isolated diastolic blood pressure component here. So to complement even our exam even more, did the point of care ultrasound here. It's just a simple 4-chamber view, and we're looking at the filling of the heart. You can see that the heart is hyperdynamic. It looks very muscular. The left ventricle looks small in size, and there is not a lot of fluid in it. So this is a low preload state. And if we do an apical 4-chamber and try to calculate our cardiac output, the cardiac output will be very high. And if we go back to our formula, mean arterial pressure equals cardiac output multiplied by systemic vascular resistance. Therefore, this is a low systemic vascular resistance state. So now, since we know a little bit more about this baby, what is our next course of action? Are we going to treat it by giving dopamine? Are we going to give fluids and then dopamine, or fluids and then NorEpi or epinephrine, or we're going to continue to monitor blood pressure? Can we take a poll here to see? Okay, I think we're seeing very nice numbers here. More than I expected, actually. Around 70% are saying to treat the hypotension and give fluid bolus to start NorEpinephrine. We still have people that are more comfortable with dopamine, and around 12%, and people might continue to monitor blood pressure, which is around 9%. So the correct answer is actually to the correct answer actually is, let me just close this, is to treat the hypotension by giving fluid boluses and then starting the NorEpinephrine, as it is a powerful vasoconstrictor. And you need a vasopressor here. So NorEpinephrine is a good option. Also, if you ruled out LV dysfunction, you can consider vasopressin in refractory cases. Let's take a second scenario. So you have a 30-weeker that was on CPAP, PPF6, and it was doing fine at 21%. Suddenly have started to have mottled skin, increased capillary refill time, and increased oxygen required, and required intubation. Was then on high frequency with a MAP of 15, a volume of around 1.8 ml per kg, frequency of 10, and FI2 requirement of around 70%. If you look at the blood pressure here, it is 39/25 with a mean of 30, which is exactly equal to the gestational age. So what is the next course in action? What would you guys choose here? Are you going to treat? Are you and give fluid and then dopamine? Are you going to NorEpinephrine, epinephrine, will continue monitoring, or treat the hypertension? Or after defining the possible physiology? Okay, great. Seeing higher numbers at this time, saying that we're going to treat the hypertension after defining the possible pathophysiology. And that's what we really should aim for, is to try to find a physiology-based approach. So let's look at the centiles here and try to figure out the physiology that we have. So 39 in systolic, it is actually low. And the diastolic 25 is above our third centile, which is 20. And the mean is actually fine. So this baby specifically has isolated systolic blood pressure. And we explained previously that the systolic blood pressure is a surrogate marker for your cardiac output. And your cardiac output is very much dependent on your contractility. So how do we complement this even more? We do a point of care ultrasound just to figure out what we have. And this is a real case. So you see that the heart here, the walls of the left ventricles are barely moving, valves barely moving as well. You don't see good contractility from qualitative assessment. So this is a case of poor contractility. So mean arterial pressure equals cardiac output by systemic vascular resistance. So we know that the problem is in the contractility in this one. So the same question again. Are we going to give fluids and dopamine? Are we going to give fluids and NorEpinephrine? Or we're not going to give fluids and start low-dose epinephrine? Or we're going to continue monitoring our blood pressure? Okay, very nice. I see that the majority, actually around 50%, is saying that we're not going to give fluids, but we're going to give a low-dose epinephrine. Around 31%, they prefer to give fluids and dopamine. And around only 6%, they will continue monitoring the blood pressure, and 11% with NorEpinephrine. This is very interesting, actually. So this is a case of a low cardiac output, and this patient actually will require an inotrope. So dopamine actually does have alpha action and has beta action. But think about dopamine as your most broad spectrum cardiac medication that will do everything. But if you have more information about what you're having, you should aim to use the most specific medication with the least effective dose to achieve your target perfusion and blood pressure. And from the information that we have from physiology-based approach and from centiles, and also looking at the cardiac focus, we understand that this is poor contractility, therefore will benefit more from epinephrine, especially in lower doses from 0.05 up to 0.1, not more than that. As more than that, actually, we will be dealing with the side effects of the epinephrine that will include cardiac ischemia, lactic acidosis, hyperglycemia, and all of that. So epinephrine is the preferred choice here. So just to summarize what we've talked about here, that the phenotypes of how babies present in neonatal sepsis is quite variable, and they can change with time. Therefore, we have to continuously try to assess those patients from the bedside, looking at the blood pressure, looking at perfusion, and getting echo to help guide our management. And also that bedside assessment, we have to realize that it has its limitation, but we should not abandon it yet until we all have enough skills. So we still have to go to the bedside, see our patient, examine and do the capillary refill, do the blood pressure, and all of our usual assessments. And we know that the extensive hemodynamic assessment is done by targeted neonatal echo, but you can still use cardiac focus if you are trained to do it. And this is just an extension of your stethoscope, a stethoscope with a monitor. Thank you very much, and we can take questions.
Thank you so much, Dr. Tal, for your great presentation, which is we really enjoyed, as Dr. Abdurrahman said. And now we are open for a question. If anyone want to ask anything, just raise your hand and we'll allow you to do so. دكتور النمري تفضل دكتور النمري.
بروف النمري.
شكرا دكتور طلال. outstanding presentation really. مع رغم التقطيع ورغم كانك وجودك في البر يا دكتور طلال، ما انت في الشرقيه ولا في الدمام. لكن احنا we have to have a يعني we already have built up evidence that we have to have a focus hemodynamic subspecialties. والquestion دائما to raise, shall we just make it as a courses workshop? Is it enough to build up the experience of our new generation of the fellows? Or shall we make it as subspecialty fellowship after they finish their neonatology fellowship? They can go and do 1 year's extension either locally or outside abroad. احنا ما عندنا للاسف الان that much numbers of hemodynamic people. ما عندنا طلال في كل وحده عشان يحدد this people need the classical treatment of dopamine to vitamin ولا لا. Shall we make more assessment for the cardiac function and choose the proper treatment? So what is your opinion?
شكرا. This is a great. يعطيك العافية Prof. Abdurrahman. This question is very much relevant and very accurate. This is the reality that we live in. I think the best thing that we can do is to look at what other people have done. And those people that are, I think, decades, have dwelled into point of care ultrasound is the adult population and the pediatric. If you look at the pediatric medicine and adult medicine, they are now, it is becoming a core competency for all trainees and fellows. At this point, I think it is difficult to have it as a core competency because you need leads in major centers all over the kingdom. And this is not feasible at this point. So I think for now, having it as something that can be learned in workshops, sessions, or by having a rotation is possible. So for example, now in Al Khobar, we're offering a point of care ultrasound rotation for 1 month. You can come in, do your NICU rotation, but you'll have special emphasis on you as a point of care ultrasound fellow. So this is one of the approaches that we can do. I don't think I have a very solid answer and fix for this, but I think it's baby steps, Alan.
Great, Dr. Talal. والرجاء الثاني, أنت you already communicate with me in regard to the hemodynamic guidelines for national guidelines, and I think we need to step in this. We need to go ahead and do it. Once we have it, maybe it will attract the people to understand more about the hemodynamic status for our premature baby, either septic or BBHN cases. I will encourage you. You have all the support from the society to start. ونحن معك. شكرا دكتور طلال.
تسلم الله يعافيك بروف عبد الرحمن، ومقدر جدا جهود الجمعية وجهودكم أنتم الخاصة. الله يجزاكم خير.
Doctor, we have a question. And if you start, you chose to start a neutral, and based on the physiology, when you're supposed to repeat echo, or how would you measure the response to the initiation of this medication, and how you want to take?
Very good question, الصراحة. So your question is actually combined question. Is when do you find the effect of the medication, and when do you find echocardiographic changes, and when do you have to repeat your echo to find your findings? The first one is actually depends on so many factors. One of them is medication delivery to the baby. And this has been also studies in neonates. It depends on what is the concentration of the medication, at what rate it is running, and if there is a chaser running. Chaser meaning you're running almost 1 ml to 1.5 ml from the IV. studies, I think they quoted around 15 to 20 minutes where you can find a change in the blood pressure or clinical response after starting the medication. Another question is, when do you find echocardiographic changes? After medication delivery, you can find changes. There are so many things that you can do to assess your response to the medication, not without doing a full echo. You can, and this is also very much established in the adult population. They are looking at VTI only, velocity time integral. It is one variable only. They will do their echo, and after that, they will do VTIs only from the left ventricle. And if they see a trend that is improving, therefore, there is a positive response to their treatment. Another thing which is your important question, and how frequent to do it. I don't think there is a certain frequency. Different centers are doing different things. For example, a very interesting webinar and conference that they presented their experience in Japan. They are doing targeted neonatal echo every 8 hours to 12 hours to assess the preload and to see if to give more fluid or not. But the problem is that their unit is, all of them are trained to do it. This is something that we cannot really do here. Another thing is you may not have people available on weekends. You might not have people available on, overnight. So I think it is how accessible the service is to you will dictate how frequent that you do it.
Okay, thank you so much. We have a question from the audience. The duration of the bolus and hypotensive preterm. Is it 10 minutes, 30 minutes, or we are based on the echo finding?
Yeah, so the duration of giving the fluids, nobody really knows what is, as far as I know, there is no specific duration. But generally speaking, for preterm babies, as part of trying to reduce the rates of IVH, is to give slower boluses and also to give judicious boluses, so not to give it haphazardly. Generally speaking, around 20 minutes to 30 minutes is appropriate, especially for the high-risk neonates. If you have a baby that is crashing and you feel that this arrest or severe deterioration due to hypovolemia, then you can probably push the fluids just in.
Okay, thank you so much. And we have a question also. If you start one of the inotrope and there is no much response and you reach the maximum dose, how you will start the next, the second line? And also, if you are planning to, is the echo influence your starting hydrocortisone or not?
Yes. So first of all, first question is, what do you do if there's no response? If you have echo available, then you will revisit your diagnosis. You have to question yourself that, am I doing the right thing or not? General rule in hemodynamics, if you are on more than 2 cardiac medications, and I try to use the term cardiac medication, not inotrope, because some inotrope have more vasoactive actions, then you are probably don't have the right diagnosis, or that you have started late. So the next step should be dictated by your echo and your physiology-based approach. You can continue to increase the doses to the maximum limit and try not to exceed that. But this is where, you know, one of the situations where hemodynamic assessment Salah is very helpful. I'm sorry, can you remind me of your second question?
Is the TNE influence your starting hydrocortisone for the preterm baby or no?
Okay, actually, at this point, no. Generally speaking, starting a hydrocortisone, if you're suspecting a degree of adrenal insufficiency, especially in the preterm babies, if they are hypotensive and or having just soft blood pressure that are not very low, we'll consider starting hydrocortisone as a physiological replacement. If you are a term baby and you are on 1 medication and or 2 medications with a poor response, starting steroids can actually decrease the required dose that you are giving. and it will get down to the minimal effective doses. And this happens by two ways. It upregulates your receptors in the heart and in the blood vessels. Therefore, you will need less medication to give the action. And also, if you have an element of adrenal insufficiency, either primary because the baby is just preterm, or it is secondary because the baby is stressed for a long period of time and is now in shock and depleted, you will replace this hydrocortisone. It will help.
There's a question from the audience about the cardiac output measurement accuracy and limitation as presence of cardiac shunts.
This is a very nice question, and Saraha, it is advanced. Cardiac output is measured from the left ventricular output, and if you have a PDA, your blood will go from your systemic circulation into your pulmonary artery and go back to the lungs again. Therefore, it will come back to the left atrium again, and it will become a cycle. That's why the left ventricle is going to be dilated. In presence of shunts, your left ventricular output is more a surrogate marker actually of your pulmonary blood flow rather than your systemic blood flow. This is one of the confusing situations, Salah. Just to summarize it, in presence of PDA, your left ventricular output is a marker of your pulmonary blood flow.
Also, a question about the name of the app you are using for mean blood pressure.
So in our unit, we're actually using centiles, but I've seen many other people using the NorEpinephrine Academy, and I can show you the website and the. So it is by the POCUS Neo group. They have so many calculators, not only for the blood pressure centiles, but also for trying to figure out the algorithm for hypertension. You can, if you are trained to do hemodynamic assessment, you can plug in the numbers that you have done in your echo, and it will suggest the possible management. So NorEpinephrine Academy.
And question, they said in case of non-available focus in NICU, like during the night, and you have one preterm with started to have septic shock, do you recommend to start by bolus plus or minus epinephrine or no epinephrine and avoiding dopamine? And also,
Okay.
if we start and you come in the morning and you see the baby have good response, do you repeat echo and you change your neurotrope based on that, or no, or you will just continue?
Okay, a very good question. So until now, there is no guidelines for neonatal sepsis, but the group in Mount Sinai, they have published their own local guidelines for neonatal sepsis, and they use a combination of clinical assessment, blood pressure centiles to try to figure out what is happening, what we just explained, the physiology driven, without the use of point of care ultrasound or echo, and they are deciding if it's more of a low diastolic. After giving fluids, they generally recommend to give 10 ml per kg multiple times to a maximum of 60 if there is an evidence of volume depletion and there is a response. And if you have a low diastolic blood pressure, to consider using NorEpinephrine as your first line. In their guidelines, they have not used dopamine at all, either in the cold shock physiology or in the warm shock physiology. Do I change my management based on the findings? No. So many times it happens that the blood pressure now is maintained with this medication that I am on. Sometimes changing the management, if the patient is stable and responding, will cause more deterioration. So waiting until the patient improves and we can wean off the medication is much better. The only reason that I will change the management if we find that this medication is actually causing more harm and more deterioration and affecting the heart negatively. But if we are guided by clinical response, there is no reason to change it.
One of the audience want to ask Dr. Nidal Younes, if you want to to share your question?
He can talk if possible. If
You are muted, Dr. Nidal. If you want to switch on your microphone, then you ask.
maybe it's raised hand by mistake or
Maybe.
okay.
Okay. Yeah, we have answered most of the relevant question and the most important. And I would like to thank Dr. Talal and all of our audience today. And also I want to thank Dr. Adan Hadid for the organization of this educational activity. Thank you, everybody, and have a good night.
Thank you very much. Pleasure to share this.
حسن النت بس عندك يا دكتور طلال ولا ندفع لك عنها ولا يهمك نوفر لك عنها على حسب الجمعيه. شكرا
بشتغل
جزيلا.
على الموضوع هذا بروف عبد الرحمن.
شكرا
جزاك الله خير.
جزيلا.
شكرا.
شكرا جزيلا. رفع الله قدرك.
مع السلامه. اهلا وسهلا.
I just added the link for the YouTube on the chat. Thank you very much. Thanks all.